Welcome back to another edition of the Heart to Heart podcast, everyone. And today, my guest is Dr. Soko. Dr. Soko is a peptide guru, and he also has a telehealth clinic called Thrive, where he does HRT for men, for women, and also peptides. So, Dr. Soko, welcome back to the show.
Yeah, thank you for having me. It's a lovely opportunity, and I'm stoked to be here to talk about maybe some testosterone therapy as well as some peptides.
Yeah, brother. Yeah, I've been following you for a while online. You've got some great videos on your Instagram, really educational. And so just before we kind of get into it and ask you some questions about TRT and peptides, can you give the audience just a little bit of a brief background about yourself?
Of course. So my name is Dr. Chester Sokolowski. I did my doctoral training at Florida State University, although I'm a diehard Georgia Bulldog. And essentially, I have been obsessed with human performance and human optimization pretty much ever since I was younger. I saw Arnold Schwarzenegger and The Predator when I was 5 years old for the first time. Not the best movie for a 5-year-old to watch, but I saw that physique and I was just obsessed with kind of pushing the bounds of what we can accomplish. How do we feel better? How do we look better? How do we perform better? And I've studied how to essentially live a high performance lifestyle. And I've tried to apply that in my personal life as well as my studies throughout my career. I've launched multiple businesses featuring that. Physique University, which touches on maximizing hypertrophy. I've launched an app. And now I have Thrive Telehealth, and we're licensed in 45 states in the United States. We're also a wholesale peptide distributor. So we essentially cover all the grounds from exercise to nutrition to pharmacology to peptides on how to enable people to literally live their best life, perform their best, look their best, feel their best, and just have, and again, a really, really high performing lifestyle. That's what we're all about.
Awesome. Well, I know there's a lot of people listening to this that are definitely interested in all those particular topics and what you guys are doing. And I know also too that, you launched a hypertrophy course that you can actually get certified in. And I noticed also when I was going over this that you did a very interesting study. And so my question about that particular study is, what are the implications of binge drinking on muscle growth?
Yeah. So this was my dissertation, and this was a good one. We're kind of in the publishing. I don't know if you've ever published, but it takes forever and a half. So we're in that forever and a half period, but the data will be out soon. But essentially, here's a little sneak peek of what we saw. So we had different groups, and the two primary groups that were very interesting were we had adult women, ages 18 to 30, and they were very active. They were very fit. They were resistance training at least 4 times per week for the past 2 years. So these were some very dedicated individuals. We kind of split them into 2 groups. One group was sober, pretty much sober, less than 1 alcoholic drink for the past year. And another group were binge drinking. And they were binge drinking. So we're talking about at least 4 drinks in about a 2-hour period. And they were doing that at least once a week for the past year. So think about 2 groups, very dedicated women. One group is pretty much sober for the past year. And the other group is partying at least once a week for the past year. So we found out that essentially they're very, very similar in terms of body composition and physical performance and visceral fat. Now, granted, you have to keep in mind these are younger women. These are 18 to 30. Young people have a very large margin of error. As you're older, that margin of error shrinks. You can't really get away with as much. You can't really recover as fast or burn as much fat. But with these women, we found very similar physical performance and very similar body composition. But we did find something drastically different that I did not predict, that nobody on my committee predicted, in terms of the metabolic health between women who were essentially sober and the metabolic health of women who were very, very fit by appearance. I mean, you look at them and you think, this is a unit of a person. This is an elite athlete, but they're binge drinking. And we found some stuff under the hood when we looked at the blood work and the blood parameters. I can't detail that yet because the study is not out, but when that study does come out, I think it's going to essentially send some ripples and maybe do a little cause for pause on, whoa, should I really be consuming alcohol in particular in a binge drinking fashion when you're generating all that oxidative stress? Because it's not really doing some good stuff for my metabolic health. And that's, of course, a nice big rainbow, metabolic health. You don't really know what that means yet, but when the study comes out, it's going to turn some heads. It's going to open some eyes.
Interesting. But so the body composition though overall, so in terms of like their body fat and their overall muscle growth, it wasn't really that different between the 2 groups?
Yeah, very, very similar. But granted, it was a crossover study because I did the study during COVID. So it's not like we have too much control over their training. And, we had like 12 people per group. So we're not talking about like a ridiculous amount of participants and things like that. But overall, very similar. But again, these were college age women mostly for them, which gives you a little bit of leeway in terms of what you can get away with for your physique. I mean, you can probably have a good night of partying when you're 22 and then crank out an amazing workout later on in the day, so it's okay. Just for that group, you probably can't do that at age 30 or 40 or something like that. So I think that behavior would definitely catch up to you and you'd see some drastic musculoskeletal differences, but in such a young age group, they got away with it.
Well, I'm looking forward to the rest of the results of that study when they do come out. And I know that, publishing can take a while, but hopefully we'll get that information soon. Just sticking on the topic of hypertrophy, there's been a lot of people that have talked about cold therapy lately, cold showers or doing, cold baths, cold plunges, whatever it is. And, I guess it's been shown that doing this post-exercise is not good for muscle growth overall. And that seems to be the consensus. But my question to you is, can that actually be beneficial for some groups? Like for people who say you're a power lifter or you're an MMA fighter and you want to get the benefits of strength training, but you don't actually want the hypertrophy. So say if you're someone, and you don't want your legs to grow. So say on leg day, you do your leg day and you get all the benefits of strength, but then you do cold therapy after to actually make sure that you don't get the hypertrophy. Is that something that would actually be effective as a tool for some people?
That is an interesting theory, and we don't have data on that. You do have to remember a lot of things go into strength. So you're going to get the neuromuscular adaptations. You're going to get kind of everything from the mind and muscle that enable strength, which is a very large portion of strength from a neural technique standpoint. But also, strength is the increase of contractile proteins. So if you do want to get stronger in the long term, you're going to have to get bigger to some extent, and you will reduce anabolic signaling with cold therapy. Now, granted, cold therapy has numerous other benefits that are outside of muscle growth. So not everyone also wants to maximize hypertrophy and be the biggest, strongest person in the world. And that's totally fine. So I think it's different strokes for different folks. If people want to do cold baths or cold showers for anxiety or something like that, more power to it. I would not encourage really anyone to do it post-workout. So if you're going to do it kind of away from that workout if you can, maybe pre-workout. Let's say you wake up, do your cold thing, and then go to the gym later and then keep it warm thereafter. That would probably be the best bet to kind of get the best of both worlds. But cold therapy can be used in certain situations, especially if your goal is not to maximize strength or hypertrophy. But to your original question, decoupling strength with hypertrophy, I think it would be a little bit tricky. And eventually, if you do want to push as much strength as possible, you're going to have to be optimally recovered. So that cold therapy might interfere with that optimal recovery.
All right. Well, thanks for answering that for us. One of your recent videos, maybe you did in the last couple months or so, I thought was really interesting. You were talking about Arimidex and TRT. And so again, for people listening, TRT is testosterone replacement therapy. And so one common drug that's prescribed for people is Arimidex, and this because it can reduce the conversion of testosterone to estrogen. But you noted that in that video, there's actually perhaps a better drug, and that would be exemestane. I think I'm saying that right. Yep. And so why isn't that actually used, say, more than Arimidex?
To be honest, I think that there is an old school way of doing TRT where basically people get, one shot a week or one shot every 2 weeks, and they get a 23 gauge needle, which if you're not familiar with needle size is an absolute harpoon that you're putting in your body, and you get a little bit of an anastrozole. I think it's like a kind of wash your hands. Here's a cookie cutter approach to the patient. It's not very individualized. And I also think a lot of these practitioners, I don't know, maybe they don't stay up to date with the research, because if you have the latest data, like what you said on exemestane, which is another aromatase inhibitor, it won't have those negative effects on the lipids. It has sort of a neutral, or some data even point to a positive effect on the lipids for lowering LDL. So I think it's a combination of practitioners had kind of an old school train of thought where they've done something for X amount of years and they don't want to change. Maybe they're not staying recent with the literature, and maybe they just want hey, here's a cookie cutter approach because I'm dealing with 1,000 patients or 2,000 patients, and I'm not going to give somebody the individualized attention they need. I just want to stick them on a program. When they come back in 3 months, 6 months, whatever it is for that particular practice, their blood work looks halfway decent in terms of the testosterone and estrogen. And most of the time, unfortunately, when people transfer to my clinic from other clinics, they don't get their lipids or their A1C or some of these other health markers that are very, very influential that dictate the optimal treatment course.
All right. And so do you ever find that those people who don't need it at all, especially when they're doing like more frequent injections, so they don't need Arimidex and they don't need the exemethastane?
100%. And you don't even have to do more frequent injections. I think it would benefit people to inject at least twice a week. But I would say in general, probably 90% of guys don't need an aromatase inhibitor. As long as your dose is pretty much under 300 milligrams per week of total testosterone, which is most TRT therapies. Anything other than that, you're pretty much juicing. Most guys don't need an aromatase inhibitor. Now, I will say some guys are a little bit sensitive to the gynecomastia, which is the tingling, the puffiness, the itchiness around the nipples, and they might need a little bit of an aromatase inhibitor or DIM. There's alternatives. You can kind of try some different things before you go, kind of crush the estrogen levels. And additionally, sometimes guys, they get a little moody. So estrogen is one of the most interesting variables in men, in that some guys, estrogen has a range, let's say like 40 is kind of the high end. Some guys, the second they get above 40, they feel terrible and they're moody and their libido's gone, and they might need a little bit more of an aggressive estrogen reducing therapeutic approach. Other guys, they can run estrogen 110, 120, and they're happy as a pig in shit. So there's no one size fits all, but I would say in general, most men, especially if that dose is below 300 milligrams total testosterone per week, do not need an aromatase inhibitor. And I certainly think if you need one, exemestane is the way to go at first. And most men tolerate that beautifully. And very rarely is your anastrozole needed, which is the one that can harm the lipids and has been associated with some increased risk of cardiovascular disease. Granted that not really in TRT patients, we need more data, but in, women who are using it for those purposes.
That's interesting, just because, I've never really heard of too many clinics doing like 300 milligrams. Like usually the dose for most people is between like 100 and 200 milligrams. And even at that dose, some people are prescribed, anastrozole. So that's interesting to hear someone say that, even up to 300 milligrams, some people don't need it at all. And again, for people who, don't know the benefits of estrogen, it can be fantastic overall for your cardiovascular health, just in improving your overall lipid profile, particularly with your HDL and your LDL. And also too, not just your lipid profile, but your joint health. If your estrogen is too low, like your joints can be really, really achy. So, I know a lot of guys are thinking, I want to crank down that estrogen. I don't want estrogen in my body. That is definitely the wrong way to go, because if you do that, your long-term lipid health and cardiovascular health is not going to be good, and your joints are going to feel terrible.
I'll add to that strength. You need estrogen to gain strength, and estrogen helps you kind of put on size. It's anti-inflammatory. So this idea that estrogen is the enemy, again, it's kind of that like old school train of thought. Estrogen is not the enemy. If you can crank high estrogen and run high estrogen, you're probably going to be a little bit healthier and make faster positive musculoskeletal changes.
And just one question about the exemethastane. I've heard this is like a permanent aromatase inhibitor. Like, what are your thoughts on that?
I think most medications and peptides, to be honest, maybe besides like finasteride, you got to be careful about finasteride. Sometimes that has long-term effects, but most of them are kind of like eyeglasses. When you're wearing your eyeglasses, you get the benefits. When you take them off, eventually things will gradually return back to normal. So I don't think there's any over dependence on some things. I think there is what can be like placebo effects that can kind of take a hold, but I don't think too many therapies are irreversible given the right nutrition, the right lifestyle, and you're just kind of living how you should live to support ideal health and a low inflammatory state.
Yeah, one more question just on TRT, because I know this comes up a lot, and there's a lot of different camps about this. Regarding HCG, are you a fan or are you not a fan?
Again, totally individualized. So there are some men who want to have a baby. And it's like, sure, man, keep your McNuggets going a little bit. There's nothing wrong with that. And there's also men who want a vanity approach of, I don't want shrunken McNuggets. So if that's the case, be happy. Don't have shrunken McNuggets. Do your HCG at, your 1500 IU per week. And that's going to be the dose that's needed to preserve your intratesticular testosterone production and your intratesticular size. In other words that are not nerdy, it just keeps your nuts from shrinking and keeps you going in terms of producing what you want to produce inside the testicles. So there's no one size fits all that X amount of people need HCG or X amount of people do not need HCG. There's specific fertility protocols where it would be highly advantageous to introduce HCG if you want to have a baby, especially if you're going to continue to use TRT and you want to have a baby. And then there's also just like, hey, aesthetics. I don't want little itty bitty nuts. And there's a lot of guys who want that, especially the older guys, after age 50, and especially older guys want to date younger women. But that's kind of like a different ballpark there. But again, it's totally individualized as to is HCG acceptable for this person or that person. You got to get to know the person. You got to get to know their goals. Anyone who says yes or no hardcore, they probably don't run a telehealth practice and treat people. They're probably not making a difference in that life. There's no one size fits all medicine. One size fails all when it comes to medicine.
All right. So regarding the HCG, so we know that it helps preserve fertility. We know that it helps maintain testicular size. Are there any other like physiological benefits though, like for mood, cognition, strength, anything else?
I mean, anytime you're going to have more testosterone, because you're going to have more testosterone, you have to account for that. So there could be more estrogen. There could be a little bit more vigor in terms of the mood because the total testosterone is going to be elevated. So you just have to look at it within the totality of the program. How much testosterone are they running? How effective is the HCG at increasing their testosterone? Because some guys, they can go very low on their TRT when they use HCG. I mean, I've seen as low as like 40 milligrams per week, and their testosterone levels are near 1,000 with running HCG at that, kind of 1,500 IU a week. So there's not like a one size fits all. You definitely have to individualize it and say, how are you responding to this? And then you adapt. It's constant communication between the practitioner and the patient. That way you can just literally dial them into having their absolute perfect recipe so they can look, feel, and perform their very best.
And you recommend people doing the HCG shots not on the days that they do the testosterone shots?
I wouldn't think it matters too much. Like testosterone, some guys like to microdose that and pin every day. And if that's the case, you're going to do them in the same time period eventually. I'd say with HCG, typically 3 times a week is the most common, and it's very effective in terms of the research, in terms of preserving testicular size, preserving intratesticular testosterone production. So your Monday, Wednesday, Friday classic approach for your HCG will probably get the job done. You don't have to go very in-depth with the HCG to get the kind of maximum benefit out of it. But as far as testosterone pinning, that is highly individualized. What size needle do you like? How often do you like pinning? There's so much that goes into your testosterone, whether you want to inject 2 times a week, 3 times a week, every other day, every day. And that is a decision that you have to balance physiologically optimal with what's practical for the person's schedule and their appetite to stab themselves with a needle.
What about semen volume with HCG? Does that increase?
It can probably have a positive effect, no doubt. Anytime, because you're looking at, what does LH do? What does FSH do? And LH is needed. Luteinizing hormone is needed. So you're kind of mimicking that luteinizing hormone. You're mimicking that LH with the HCG. So you're kind of getting a little bit of what you need to produce and preserve a little bit of, what you need to have them kids. Now, granted, if you do want to have kids, there's a specific fertility protocol, and enclomiphene would probably be very, very beneficial to add. And then each person, when you add the HCG, when you add the enclomiphene, that's different based on their timeline to get pregnant. That's different based on how aggressive they want to be to get pregnant. You're like, hey, let's do it right now. I'm really sure my, female person is, X of age and it's absolute perfect timing, or, 6 months from now. There's so many variables to consider. And also whether or not the person wants to stay on TRT, stay on exogenous testosterone, or get off of exogenous testosterone. And you got to weigh variables like what else is available. Do you have recombinant FSH? So there's so many different factors that go into optimizing fertility and using some of these resources, your recombinant FSH, your kisspeptin, your enclomiphene, your HCG, the list goes on. But fertility is quite interesting to maximize that in each specific scenario and meet each goal and each demand.
All right, so thanks for covering those questions on TRT. I'm going to move on to peptides now. And let's just get into the most interesting or popular category, which is GLP-1. So these are your drugs like Ozempic, Mounjaro, and the new one now, Retatrutide, which is in clinical trials, but not yet available for most people anyway. So with the GLP-1s, like the thing that you hear, and I think this has been disproven for the most part, but you hear that, if you take GLP-1s, you're going to lose muscle. And, I'm sort of reminding people that like anytime you're in a caloric deficit, you're at rest, you're at risk of losing muscle. So if you're on a GLP-1 and you're in a caloric deficit, sure, you're at risk of losing muscle. And again, these studies, they were done on like the general population. So if you did a study with GLP-1s on people who strength train, eat protein, and have healthy hormone levels, wouldn't you see different results and perhaps no muscle loss at all?
Yeah, 100%. And to be honest, if I had to hypothesize, I would say microdosing, very low dose GLPs might help you gain muscle. Because think about what they're doing. They're reducing inflammation. So you have an anti-inflammatory environment that tends to be pretty good for muscle growth. And then you are shuttling glucose into your skeletal muscle. So you're taking glucose from the blood and helping put it into muscle cells. When glucose is in muscle cells, it can be used as fuel to link together amino acids and keep protein synthesis going. It can be used to fuel growth. It can also be used as muscle glycogen. So you can have more energy stores for more longer, intense workout. And also you're going to have lower, essentially, glycogen is very, very important to relate to muscle breakdown. The lower your muscle glycogen is going into a workout, the more skeletal muscle breakdown you're going to have. So again, you take the glucose out of your blood, you put it in your muscle, you're going to have more muscle glycogen, which could avoid catabolism for longer, more intense workouts. So maybe less muscle breakdown during training and then more growth after training to fuel essentially the optimal physique, the optimal recovery. So I think GLPs, when dosed properly, and oh my gosh, they are not really dosed properly in the research. They are crazy dosed in the research. When dosed properly, could be, I think, very advantageous. We actually have a few IFBB pros in my clinic who do some GLPs in very, very small doses, and they can see fabulous gains. They use them in their off season. Me personally, I use a GLP and I can use it for a maintenance phase, which I ended up losing weight. I've used it for a cutting phase, which it was incredibly easy. I'm doing that now to lose weight. And I've used it for a massing phase in terms of having a purposeful calorie surplus. And I feel like it helped me maintain fabulous insulin sensitivity, maintain low inflammation. And I feel like it helped me grow muscle at a faster rate in my off season.
That's incredible. Yeah, I think a lot of people probably need to hear that because I think, that myth that it, causes muscle loss has been perpetuated like quite a bit. But, in terms of the dosing, like the half-life of the GLP-1s is so long. Like I think it's about 7 days for Ozempic. I think it's 5 or 6 days for Mounjaro and Retatrutide, somewhere around there. So why would people need to take it, daily instead of weekly if the half-life is so long?
I don't think daily. I think you got to balance physiologically optimal with practical. I would say either, 2 times a week to start with when you're kind of first getting acclimated, very, very low dose, and then maybe 3 times a week. That would probably be enough to kind of fit the bill, fit the mold in terms of what you need. So you don't have to inject yourself too much, but you definitely want some form of hormonal stability. Whenever you're dealing with hormones, whenever you're manipulating hormones, when you have a big peak, when you introduce a hormone in a large dose, you're going to have a peak and then a crash. So we don't want people to ride waves with their hormones if they don't have to. We don't want ups and downs. We don't want peaks and valleys. When you kind of just think of like gender differences, like who's easier, men or women, in terms of dealing with hormonal issues. Men have it so much easier because we have hormonal stability. So the same concept applies not just to the sex hormones, but the GLPs, because essentially they're mimicking hormones. So you want stability, you want levels that are not going up and down. And I think, to be honest, especially in the research, these GLPs are dosed at such high doses, and you're basically just getting a beyond therapeutic dose for the beginning of the week. You're pretty much like injecting a stomach ache. And then the latter portion of the week, when you're way away from your shot, you might be getting a little hungrier again. And that doesn't facilitate good eating patterns. I think that's why muscle loss occurs, because you have extreme appetite suppression driven by nausea and side effects. So, anytime you're in a calorie deficit, you're going to experience that. And I think it's exacerbated when you do too much of a bulk dose with a once a week shot. So even though something has a half-life of 6 days or 7 days, does not mean you have to do it every 6 or 7 days. And similar with testosterone cypionate, I think dosing at least 2 times, because it has a similar half-life as the GLPs. I think dosing at least 2 times, potentially 3, 4, potentially every day could be advantageous for testosterone cypionate. And then GLPs, I think you get a fabulous bang for your buck at pretty much 3 doses per week. Very, very advantageous to see those positive changes while minimizing the negative side effects.
So maybe we can get a little bit specific about Ozempic, just because, that one does seem to be, from my understanding, at least the most popular still, but we'll talk about the other ones as well. But for Ozempic, they start off at 0.25 milligrams a week. People usually do that for 4 weeks. Then they go up to 0.5 for another 4 weeks. Then I don't think there's a 0.75 for 4 weeks. I think then it jumps from 0.5 to 1 milligram. But then it tops out, I think, at 2.4 milligrams, if I'm correct. So let's just say, 1 milligram, just for simplicity's sake, just because that's, an easy number. So if someone was going to take 1 milligram a week, you think that doing, say, like 0.33 milligrams 3 times a week would be more beneficial overall. Is that correct?
100%. And I actually just pulled up our dosing chart. So if we were to do, let's say, 1 milligram, right, of semaglutide, kind of your Ozempic.
And do you think that's a high dose, 1 milligram a week?
Yeah, so I was about to touch on that. So okay. I'm a big fan of tapering up with the GLPs. You start really, really quite low, and then you taper up. So by the time we reach 1 milligram in sort of our custom-made protocol, that's at week 16 of dosing. Wow. So most people probably could have lost all the weight, or at least a significant portion of the weight, in 16 weeks. So that's 4 months. So essentially, they might not ever even touch 1 milligram. They might taper it up and then taper it back down. And then they might run a micro dose of something like Reta, because Reta may have a little bit more diverse health benefits. But essentially, again, less is more with these GLPs. I think that's the other great benefit of microdosing. You do not have to take nearly as much, because remember, when you're dosing once a week, you're injecting so much at the beginning, and it kind of has to last you until, let's say you're injecting Monday, it kind of has to last you until Saturday, Sunday. But when you microdose, you don't have to do like, okay, this dose Monday has to last me and curb my appetite over the weekend. You can just do nice, smaller portions, much more manageable, much fewer negative side effects. And I think that is going to create an overall decrease in the amount that you have to use. And that's going to minimize side effects and help you maximize results without that distress.
So when you're talking about too high of a dose, you're not necessarily even just talking about too high of a dose, like in terms of injections throughout the week. Like you're talking too high of a dose overall, meaning like you don't necessarily think many people need to go higher than 1 milligram. Is that right?
Some people might. I mean, there are people who have to lose a significant amount of body weight. So if you have to lose 100 pounds, you got to taper that up. And I think what you also can add, and this is kind of coming out, I don't think it's yet available for most people, but it's cagrilintide. It's an amylin analog. It's going to suppress your appetite. It's another mechanism, if you will, where you can have a little bit of improved insulin sensitivity, a little bit of appetite, actually pretty much significant appetite suppression, and a little bit of slow digestion. So you don't have to necessarily abuse kind of that one receptor, that GLP-1 agonist receptor. You can use a diversity of receptors. And I think that might also keep the cumulative dose of your GLP-1 lower, your GLP meaning Sema, TERS, or Reta, whichever one you use.
Okay. But for people who, need to lose a ton of weight, and like you said, medicine is individualized for sure, but you do think that 1 milligram a week overall, spaced in 3 times a week is like a sufficient dose for, a good portion of people. Is that correct?
It can be that would be a pretty healthy dose in my eyes. But again, if you have to lose a significant amount of weight, you can go past a milligram. You have to do what's necessary. You have to weigh the pros and cons of, okay, what is the downside of tapering up the dose? Then what is the downside of carrying X amount of body weight or having an A1C that's diabetic, or all those negative side effects that come with excessive adiposity, with having too much body fat. So again, just weigh the pros and cons. And I also think it's very important to set someone up for success long-term. So if you're tapering up, if you're gradually increasing the dose, you have to gradually decrease the dose. Like, if there's one thing we've ever seen in research kind of before GLPs, it's people can lose weight. They can't keep it off. You have to set them up with the lifestyle habits, with the exercise, and with the proper tapering up and tapering down to coast and have success, not just losing the weight, but keeping it off while using your GLP.
But would you be okay with someone, using it lifelong?
Yeah, personally, I can't see, for me, I use Retta personally, and I don't know if I'll get off of it because of all the beneficial health benefits, in terms of endothelial function, in terms of blood pressure, the insulin sensitivity, reducing inflammation. There are so many diverse health benefits that extend beyond fat loss. I almost have a theory that America is probably one of the least healthy countries, especially in terms of how much money we spend and the results we get. I think if most people used a microdose of a GLP and glutathione, I think within 5 years, we could probably go from the most unhealthy country in the world to probably the healthiest country in the world. That's just my personal hypothesis.
Okay. And with the retatrutide, we'll maybe come back to Mounjaro because we, kind of hammered Ozempic pretty good there. But for retatrutide, that study, I think it was in the New England Journal of Medicine, maybe it wasn't, but they were using doses, I think, up to 12 milligrams a week. Do you think that is just way too high of a dose? And again, I know that, medicine is individualized, but do you consider that to be a whopping dose, and that most people could get away with maybe, 2 or 3 milligrams, or maybe even half, 6 milligrams? What are your overall thoughts on the 12 milligram dose of retatrutide?
Yeah, so I wrote a dosing protocol for Retta, and if you were to follow the protocol tapering up, the 12 milligram would be at week 39.
Oh,
so
wow. Okay.
You would be almost a year into using Retta to use 12 milligrams based on the research and on the data. And I think an appropriate starting dose of Retta is probably 1 milligram per week. And then you bump it to 1.5 and then 2.25 and then 3, but very, very small incremental doses. And to be honest, most people could probably chill somewhere around 1.5 to 2.25 milligrams per week of Retta and be very, very content, get a whole bunch of health benefits, quiet food noise, make it much easier to be healthy, to eat right, to stay lean, to keep inflammation low, to keep a great lipid profile, to keep very, very insulin sensitive because you have those 3 receptors with Retta. So I think, again, less is more on some of these GLP doses.
Interesting. And then with the Retta, again, even though I guess this will make it even more significant because the half-life is a little bit shorter. I think it's more like 5 days maybe versus 7 days for Ozempic. I think Ozempic is the longest. You would definitely want to use that about 3 times a week instead of once a week overall.
Yep. All the GLPs, I'd probably recommend starting twice a week, very, very small dose, just to see how your body reacts, and then bump into 3 times a week. And I think that is absolutely ideal. If you don't hate pinning yourself, or if you notice you have days where you have unusually high cravings, maybe you increase it just a little bit, but again, keep that individualized. I think 3 times a week is very, very good, very sufficient to get the results and minimize the side effects for 99% of people.
And in terms of, increasing the dose, and like you said, I think, in medicine, it's always best to, start low and go slow. But for the reason doing that for retatrutide, is that mostly to decrease the side effects, or are there some people who, just can use a higher dose, say they increase it, let's just say hypothetically by 2 or 3 milligrams a week and they don't get side effects? Is that just an individual thing, or what is the approach in terms of using a smaller microdose and using a smaller increment per week? Is it really just to decrease the side effects overall?
Yeah, I think it does minimize the side effects, but also if you don't have to use a lot, don't use a lot. You know what I'm saying? If you can get great results on a smaller dose, then there's no need to push it. If your appetite is suppressed, if you're losing X amount of weight per week and it satisfies your goals, it satisfies your desires, then you don't need to keep increasing the dose. So you can essentially stop the taper and have a maintenance dose. And then let's say, hey, you wanted to overcome a plateau, or you wanted to have a specific phase where you're a little bit more aggressive and you wanted to push for some more weight loss before a wedding or something like that. Then maybe you can taper up that dose to meet that specific goal. Then you taper it back down to your nice, healthy maintenance. So I think that, again, always individualized approach. And I think that puts people in their best position to excel regardless of their goals. It's just about adapting. It's about learning your body and adapting to the GLPs.
And so regarding the 3 GLPs, so, Ozempic, we know, has one mechanism of action. It's the GLP-1. The Mounjaro is a GLP-1 plus a GIP. And then the Retatrutide is a GLP-1 plus GIP plus a glucagon.
GR. Yep.
Okay. And so regarding the last one, the Retatrutide, and this is really interesting because you did a video on this. So the GLP-1 and the GIPs, I think most, if not, not all, but most of the beneficial effects come from the reduced appetite in terms of, losing weight and helping people just get healthier in general. Obviously, there's going to be, reductions in A1C and some other things that you mentioned as well. But for the Retatrutide in particular, like you said that you didn't change your exercise regimen, you didn't change your eating habits overall, and you were still losing weight on Retatrutide. So that seems to have like weight loss like independent of your caloric intake, which makes it a little bit different from the other GLP-1s, correct?
Yeah, Retatrutide is kind of a unicorn in terms of what it can do. So it has the GR, that glucagon agonist receptor. And basically that can increase your metabolism. It can change the activity of proteins in your liver. It can also change growth factors, and you can end up actually burning more calories on Reta. But that's only one of the reasons why Reta is great, because of that glucagon agonist receptor. The other reasons why Reta is great, because they modified the affinity for the GLP receptor and the GIP receptor. So that GLP receptor, that's the one that's going to be the alpha in terms of appetite reduction. They only made that about 40% as strong as your natural GLP hormone. So what does that mean? You only get about 40% as much of the appetite suppressive effects with Reta. So that means Reta's probably not for everyone. You have to have some dietary discipline. It's kind of just enough to quiet food noise. But if you really wanted to throw down some tacos or snack or whatever it is, you could probably do that on Reta. So you have to be pretty good with your discipline and your meal planning to make the most out of Reta, because it doesn't have those dominant appetite suppressive effects like Sema and TERS. Now, what makes Reta so amazing is the affinity for the GIP. And what the GIP does is it's going to essentially, when there's low insulin, it is going to trigger the breakdown of body fat. So it has 8.9 times the affinity for that GIP receptor. So that's potentially 8.9 times the affinity. That's potentially 890% more fat breakdown than your natural GIP hormone. So that makes Reta so incredible, just enough to quiet food noise, incredible to break down body fat, and then you couple that with the potential increase in metabolic rate. So Reta, again, is so amazing because I think it's the first time we were actually like not messing around, F around and find out. Like, we were actually strategically designing something to lose body weight. We were not just helping people eat less, but we're helping them burn more. And we're also increasing the essentially fatty acid pool where we can generate energy. And if you couple that with other peptides like a MOTC or carnitine or a tesofensin, it just makes things even better for overall fat loss. But Reta is truly the unicorn in terms of what it can do, because it has so many diverse benefits, and particularly that fat breakdown benefit that is hands down clear cut, in my opinion, above the rest. And I get that from, kind of the various experiences that people have had with it.
Very interesting. And so I had Dr. Sean O'Mara on the show. I'm not sure if you're familiar who he is, but he's really big into visceral fat. That's kind of his like go-to thing. And he helps people decrease their overall visceral fat. And he does, MRIs and all this kind of stuff. And so for people who aren't aware, like, visceral fat is that fat that's around your organs, and that seems to be associated with poor longevity or increased all-cause mortality. And so With the retatrutide, would you expect that to be more effective at reducing visceral fat than the other GLP-1s?
I think they're all pretty effective. I know we have some data that Reta does help reduce visceral fat, but I think all of them are effective. I think in general, losing body weight and changing some of these behaviors of people, which I think the GLPs can do, is going to be conducive to losing visceral and subcutaneous fat. If you really wanted to crank up the visceral fat loss, you'd probably introduce something like testosterone. Like you'd use Reta and testosterone, because testosterone is another amazing one. FDA approved to shred fat. In particular, has great data on the visceral fat to shred that fat around the midsection, around those internal organs. That you're right, that tends to cause diseases. So if you wanted to do peptide stacks, stacking Reta with something like testosterone would be incredible, and it would just speed up the process because testosterone is something that boosts growth hormone, can elevate IGF-1 to help preserve muscle. So there's so many various benefits of peptides. But yeah, in terms of visceral fat, I think all the GLPs would be effective. Reta, just due to the potency of effects, might be a little bit amplified.
So regarding the brain effects, because I know there's a lot of people who are very interested in using GLP-1s just for the brain effects and like basically decreasing impulse control. And so you mentioned earlier that, retatrutide is maybe only about 40% as effective as the other GLP-1s in terms of reducing appetite. And so would that make it potentially, though, a little bit less effective for someone who wants to use it for impulse control?
It might, but I think it's still powerful enough to have that impact. I still think it's enough. It's like, is Reta enough to reduce your appetite? And you go, yeah, if you ever used it, especially if you got past 2.25 or 3 milligrams, you certainly do feel that appetite suppression. And we've had really good success in this clinic of people vaping or doing cigarettes or some negative behavior and adding a GLP to reverse the desire to do that negative behavior. So I think that all the GLPs can be pretty effective within that. And I think Reta, even though it might not have as strong in theory of the other kind of potencies of that GLP agonist, I still think it's enough. It's enough to do the job. But again, it probably would depend on each specific person's desire and addiction and behavioral habits and things like that. But again, I think most people would benefit from microdosing GLPs, and this is just one of the various other benefits that you can do. And in general, people always feel more energetic and happier seemingly on GLPs because their inflammation is down. Just another added benefit of those GLPs.
Yeah, I mean, obviously don't get too specific with names or anything, but maybe you can talk just a little bit more about, some of the patients that you have on GLP-1s that have had, reductions in some, unwanted behaviors like smoking. Because this to me is really fascinating, the idea of impulse control. And I had, one friend recently, he told me that I couldn't believe it. And he's, a legit, he's not a crazy person. He's a legit dude. And he was on Vyvanse, for years. And then he started taking Mounjaro, which is, again, the one that we haven't talked about. So that's a GLP-1 and a GIP. And he said that, he was able to stop his Vyvanse just because his ADHD was better controlled. And so, are people telling you that they just feel less impulse control in general, and that's why they're able to stop behaviors like cigarette smoking? Or what is it specifically that people are saying?
I think it's partially that, and I think it's partially mood. Because whenever you cut weight, you're kind of a miserable person. Your nutrients they're the resources you need to survive. So you need nutrients to survive. If you deprive yourself of the resources to survive, you can get really tired, really cranky. But when you cut on GLPs, it's almost like you avoid that kind of negativity. You might be fatigued, especially if you calorie deficit for a long time, but you're not as cranky, you're not as moody when you're cutting weight, but you're seeing these positive changes in your body. So maybe your confidence is potentially growing a little bit and your mood is a little bit elevated. And then you couple that with less of this kind of impulse control, impulse desire. So I don't think it's one particular factor. I think GLPs, or just fat loss in general, can elevate someone's mood, especially when fat loss doesn't have to suck in terms of you feeling so fatigued and hangry and all these negative things that are typically associated with fat loss. They just make losing weight so much easier. That's why, again, most people could probably benefit from GLPs. in one way or another. And they're not like a crutch. It's like, why would you make something more difficult than it has to be when there's so many tools, so many resources at your service that can make things easier? A lot of people are like, I want to lose the weight myself and I want to do this. It's like, man, it helps with your behavior. It speeds up the process. It makes the process not be as terrible. That's why I like to take advantage of them. My parents like to take advantage of them. Family members like to take advantage of them. They're just a tool in the toolbox that are incredibly useful. And based on all the data that we have, I think they're very safe, and I think they're safe long term. I plan on committing them long term. We had the first FDA approved GLP in 2005, I want to say. So these are things that have been around for 2+ decades. And they had research before that. Obviously, you need research to gain FDA approval. So I think that these things are kind of tried and true and have so many different benefits. And maybe one of the biggest benefits is when you cut, your mood doesn't suck. Like, you don't become as miserable of a person when you're in a sustained calorie deficit. And most people at some point are going to become a miserable person when they're in a sustained calorie deficit.
Yeah, I've definitely heard that a lot in, bodybuilding circles, and that girls, when they're cutting, like, don't get around them, they're going to be super bitchy and stuff like that. So, knowing that, this is something that can help is fantastic. And what you said too, like, it's just like a tool. And, we don't criticize other tools. Like, I always tell people, like, one of the first things to do when you want to lose weight is just get all the junk food out of your house. Because, like, for me, like, I don't really claim to have like superhuman willpower. Like, I don't eat any junk food because there's no junk food in my house. Like, the worst thing I can eat is like, a protein bar, like a Quest bar. It's like, so, why not just have like another tool that can, be helpful for you in terms of losing weight? So yeah, you answered most of my questions that I had there on GLP-1s. So, thanks so much again for doing that. But you mentioned glutathione. And so do you feel like glutathione pairs well with GLP-1s? And if so, why?
I think glutathione pairs well with pretty much anything. It is so good. I think it's the most powerful antioxidant we have. It's going to reduce your oxidative stress. Why do we want to reduce oxidative stress? Because high oxidative stress is associated with cardiovascular disease, with cancer, with Alzheimer's, with Parkinson's, with stroke, with diabetes, with all these negative things that occur in our body, all these diseases. So if we can reduce oxidative stress, you're going to be healthier. You're going to prevent disease in some capacity. And glutathione, in my opinion, is the best healer of the body. It heals the body from the inside out. So your liver, your kidneys, your endothelial cells. I mean, nobody cares about those things, but if you ever want healthy blood vessels and minimize your cardiovascular disease, you want really good endothelial function. And then the skin, like, your skin just glows, dark spots, wrinkles, acne, they tend to dissipate. It's easier to preserve the hair on your head because you have better DNA, you're mitigating inflammation, there's less, again, oxidative stress, all these different things that typically lead to premature balding. If you are on top of your P's and Q's in terms of thyroid hormone, then you have low inflammation, low cell stress, good healthy DNA. The odds of you going bald are not very likely unless you have just very, very strong, androgenic alopecia, which can be controlled to some extent with some certain topicals and things like that. But overall, glutathione is, in my opinion, one of the best, if not the best, anti-aging peptide that you can use. And it's naturally found in all the tissues of your body. That's the beauty of peptides. They're not artificial signaling like, for big pharma, pharmacology. They're doing what your body naturally does. Unfortunately, we just make less of these things as we age. So if we introduce them, we can kind of recreate the physiology we had when we're in our 20s. And who doesn't want that?
Absolutely. And in terms of people who say, come to your clinic and they can't get access to glutathione for whatever reason, would you suggest them to use N-acetylcysteine or NAC?
I would say, I guess some is better than none. NAC might convert to glutathione. It might not. So NAC is the precursor. First thing, I would just move to America. I know you're in Canada. I would just move to America, get you some good access.
I'd like to move to America.
Yeah, that's really the solution. Just move to America instead of do NAC. It's way more practical. It's way easier.
And so what would be the best protocol for glutathione if you were to start it and you were to start injecting it?
So I like to do it daily. A lot of clinics, they kind of IV it. I don't think you should do that. It's an antioxidant. If you have too much, you might, excrete it and waste it. Essentially, you want to just kind of do a little bit. You don't want to oversaturate the cells. So I think a little bit every day, could be IM, could be sub-Q with a very small insulin syringe. So, 31 gauge. 5/16 of an inch. Pretty much everyone can tolerate injecting that. I do think daily is the best route. If you hate pinning yourself, then every other day. But I think, again, those microdosing approach, the smaller approaches, so you kind of have just a little bit enough in your cells, that's going to make the difference to maximize it and use the most of it, so you don't, again, have too much and oversaturate the cells, and you don't have time to use it. Next thing you know, you excrete it and you're wasting it. So yeah, smaller approaches, IM or sub-Q pens, those will work just fine.
And so what dosing would you do if you were going to do it sub-Q daily?
So we do typically, it's a 200 milligram per milliliter vial. We inject 0.3 ml. So what's that math, about 60 mgs a day?
Yeah, I mean, that's something that gets, brought up a lot. And, I have some friends who, own compounding pharmacists, and they say that's one of the number one things that people reach out to for is glutathione. And it's not something that I've, used before. So we're kind of looking forward to maybe, introducing that. In terms of, other peptides that we haven't talked about, do you think that the copper peptide is the best cosmetic peptide for the skin?
I'd say it's a toss-up between that and glutathione. I would give GHKCU, the copper retaining peptide, maybe a little bit of edge on skin elasticity and wrinkles. I would give, but it's also pretty decent with dark spots, and it's also the best we probably have for hair loss. I would maybe give glutathione a little bit of an edge for definitely acne. Glutathione and acne. Inflammation and acne, huge role, very misunderstood. But I would definitely say glutathione and acne is going to be the best, as well as maybe some dark spots. If you just want a really smooth complexion, maybe glutathione. But if you really want your best skin, you would invest in glutathione and GHKCU.
Okay. In terms of peptides that increase growth hormone, it seems like there's several of them, outside of, say, the GLP-1s for appetite reduction. It seems like most of the peptides, more or less, there's just one in each category. But for growth hormone, there's a ton in that category. And so, there's ipamorelin, there's CJC, sometimes those are combined together. There's semarelin, there's others I think that I'm definitely missing here. Which one would you consider to be the best overall?
So I'd say the alpha by itself would be testosterone. That tends to give the best blood work responses in terms of your IGF-1. And you don't really measure growth hormone in a blood test because the half-life is so short. You typically use IGF-1 as a surrogate. Now, granted, you got to be in a calorie maintenance or surplus. If you're in a calorie deficit, your IGF-1 is going to be tanked regardless of what you do. But I would say testosterone is probably number one. And then I would say it's a combo. Number two, and this is maybe 1A and 1B. So 1A is testosterone, 1B is a combo of ipamorelin and CJC. So CJC and ipamorelin, 1B. If you had to do solo IPA, I'd put that as 2. But typically most people do the combo of CJC and ipamorelin just to augment that different that growth hormone response. And then for whatever reason, probably because, again, this is the old school train of thought, how we started the conversation on TRT, sermorelin, sermorelin, you're going to get a response, but typically you have the most side effects, most reactions in terms of itchiness and things like that. And you probably get the poorest, the weakest IGF-1 response out of all of them when you look in the blood work. But for whatever reason, if you go online or if you go to most clinics, sermorelin is probably the most popular. It's the least effective out of the big three, but the most popular. Don't know why.
And in terms of timing of injection, I've heard that for secretagogues, all these peptides, they need to be injected on an empty stomach. Is that true? Because I saw that, one video you posted, you said to do it pre-workout, and, maybe you are fast at pre-workout, maybe you aren't. But I guess the question I really have for you is, does it have to be done on an empty stomach?
Yeah, I wouldn't say you have to fast for X amount of hours. I probably wouldn't eat an hour before, and I think that might give you a little bit more robust growth hormone response. Because remember, we're talking about your natural growth hormone, not exogenous growth hormone. If you inject exogenous growth hormone, you're going to jack up your growth hormone no matter what. And you're going to then subsequently increase your IGF-1. Sometimes with natural signaling, if you have certain conditions in your body, it might limit your natural growth hormone secretion. So I think Fasting is typically when you see a very large portion of natural growth hormone be released. So we're probably just trying to mimic those conditions. As far as injection schedule, testosterone is very, very common before bed. If you're not doing testosterone, maybe CJC ipamorelin before bed. If you're doing both, which I do both and I love both, your testosterone before bed, and then your CJC ipamorelin pre-workout. Again, when do we make a lot of growth hormone? When we're about to resistance train, and it's just you're playing off some of your body's natural abilities to elevate growth hormone. So I would say when you go to bed, testosterone is really good. Pre-workout, CJC ipamorelin. And then if it's not a training day and you still want to increase your growth hormone response, then maybe you wake up and you do your CJC ipamorelin, maybe before some cardio or something like that. I think before you get moving, that's typically how to get a really good, robust response from your growth hormone secretagogue, or before you go to bed, because during sleep, you're going to knock out and you're going to release a lot of your natural growth hormone. We just want to augment that.
All right. So outside of GLP-1s, I'd say the most popular peptides would be BPC-157 and TB-500. So would you recommend to do always those two together?
I would say this is just based on anecdotal reporting. I would say BPC by itself, maybe 75 to 80% of people see a positive benefit. That's pretty solid. That's pretty solid. It's just a high C or a B. But if you do BPC and TB-500, I would say it's anywhere from 95 to 97% effective. And this is talking about a lot of the sources are like BS from China, or some country where you're getting mystery meat as powder. This is like really high quality product, domestic source in the proper facilities where BPC and TB-500, where peptides should be made. But I would say when you combine them, you have a significantly increased ability to have effectivity. Because remember, it's just like, what are they doing at the physiological level? Well, your BPC is essentially going to increase your sensitivity to growth hormone. It's going to increase growth factors, can help with a little bit of the inflammatory response. And then your TB-500, it's going to help cells to get to the wounded area. It's going to help angiogenesis, creation of those new blood vessels. So you're really going to help those growth factors and that growth hormone get to those areas of need, get to where kind of those hard to reach places, those tendons, those ligaments, those things that don't really get a lot of nutrients or remove a lot of waste because they don't have a lot of blood flow. So I definitely think there's an advantage from a mechanistic standpoint of stacking them. And if it were me personally, I wouldn't probably spend the money without stacking them, just because I want it to be effective.
And in terms of BPC-157, what are the differences in the effects in terms of injecting versus taking it orally?
Oh, huge differences. So essentially, if you inject, you can get 100% into circulation. Now, it's going to be systemic. It's going to travel throughout your body and help various tissues, okay? Various organs, tendons, bones, ligaments. Anecdotal reporting says if you have an injury, let's say your shoulder's injured, the closer you get to your shoulder with that injection, the better it's going to be. You don't have to inject near your shoulder, or you don't have to inject near the area of need. But if you get closer, people say, and I would probably agree with this based on personal use, that you're going to have a little bit better response. Now, as far as the orals, most of the oral peptides, they're going to just kind of get stuck in the gut, So if you have something, like testofen, that's not going to get stuck in the gut. That's going to travel everywhere and make you really happy. But something like your KPV or your BPC, that's pretty much going to be localized to the gut and not have those systemic effects. So I think if you can inject it. That's going to be a better bet to maximize the bang for your buck and ensure that you're getting the effects that you want. And also with the injections, like you're still going to get all those benefits in the gut itself. You're just going to get benefits elsewhere. So again, I think if you want to maximize the effectivity, make your dollar stretch the farthest when you invest in peptides, injection would certainly be the route to use.
So there's not really any unique benefits then to injecting it, to taking it orally. Like, sure, you'll probably still get the benefits in the gut, but you're not going to get necessarily benefits anywhere else. And if you do inject BPC-157, you're going to get the benefits everywhere else, and you're going to get the benefits in the gut. But the benefits in the gut from the oral BPC are not going to be better than, say, the benefits in the gut from the systemic BPC. Is that correct?
Correct, 100%. And I also think when you talk about like gut, the gut is like a big old rainbow of stuff. Like it's so many different things. A lot of people are like, oh, I have leaky gut. When in reality, they might just have a shit diet, so like they got to be real with themselves. And, oh, is this really BPC or is it something else that's needed? And I would say 99% of the times it's like a dietary and lifestyle intervention rather than true leaky gut.
Okay. And with TB-500, so, there's TB-500, there's also TB-500-1723. Do you always recommend people just use TB-500 and to skip over the 1723?
Yeah, I think, if it ain't broke, don't fix it. Like, you just want the derivative of thymosin beta-4, which is that natural protein that you're going to make. TB-500 does the job. It's tried and true. Personally, when it comes to peptides, this is just maybe me. I don't like to go super, super overly nuanced. I like stuff with a little bit of research behind it. Because when you go super, super nuanced, you risk side effects in terms of what has not been discovered. So if there's something that ain't broken, let's not fix it. Like, we have tried and true protocols that work, and they seem to be pretty safe and long-term safe, and we've been using them for decades. That's going to be a good route for me, So I just don't see, pros and cons. If something works and it has, like I said, maybe 95 to 97% effectivity, that's good enough for me.
And so what do you think about TRT in sports and peptides? Do you think that this should be allowed in all the major organizations?
That's an interesting question. So I think peptides probably, but at the same time, then some of the best athletes would just be the athletes with the biggest pocketbooks, because these things can get really expensive when you talk about some of the performance enhancers, especially growth hormone. Like, I honestly think like being an elite level bodybuilder, for example, is who can afford the most growth hormone and who can do the most quantity of PEDs without their internal organs giving out. So it kind of changes and slants the field. But I think there was like a hockey player who got suspended because he was
Ekblad. I was going to bring that up.
He was using BPC. Like, yeah, let the man recover. Like that to me is ridiculous. So yeah, certain ones I definitely think they should be permissible. And remember, sports are entertainment. Like, we want to see our best athletes out there. So if somebody's hurt, and they can have a quicker recovery with BPC and TB-500, let's get the entertainer out there. Let's let him do his thing. Let's let him operate at 100% and not, cripple or risk an injury or whatever it is. So I think not just from the athlete standpoint where they can take advantage of some of the peptides, but the fan standpoint, some of the peptides are certainly permissible. Again, we probably got to have some sort of limitations, because you can get crazy, especially like, oh, this guy's on 15 IU of growth hormone or something like that. There's got to be some restriction. But yeah, like BPC, TB-500, maybe some NAD, like, sure, man, go ahead.
Yeah, I think so too. I mean, I don't think, again, it should be like a free for all, like we, got to do this like slowly kind of thing. But I think if we were going to reintroduce some of these things, or not reintroduce, introduce some of these things into sports, the healing ones would be the first ones, I think, because, so many guys get injured and, they're missing games, and, it causes, fans to be upset too, because their, favorite players are out, and, they may buy a ticket for a game, and then all of a sudden when they go to that game, the player's injured. But things like TB-500 and BPC-157 that are not true performance enhancers, they're just essentially healing agents. I think those things should definitely be included in professional sports. And yeah, I just think it's ridiculous that, Aaron Ekblad got suspended for that. And like, I'm not sure how much about hockey being an American, but like he's an amazing player, and like luckily they were able to recover, and they still won the Stanley Cup, so it didn't really affect them. But it could have been a lot worse, and so I just think that players should be allowed to use peptides for healing purposes. I know that I only had you for an hour, and I've already gone over an hour here. So, just please let everyone know, where they can find you on Instagram. And like I said, your Instagram channel is amazing for, educational stuff on peptides, TRT, and everything that we talked about today. But just let people know where they can contact you regarding your clinic and anything else that you have going on right now.
Well, it was fun. An hour flew by.
I know, I couldn't believe it.
Yeah. Wow. I felt like we barely scratched the surface. Like, we didn't even talk about NAD or really cagrilintide.
Well, you're going to have to come back on. I'm putting pressure on you.
Okay. I'm down. Okay.
Appreciate
so my Instagram, Dr. Soko, Dr_SOKO, and I got a number of different kind of sub handles to that. But yeah, Dr_SOKO. If you want to work with me in America, it's thrivehrt.com. So THRIVE, so thrivehrt.com. But yeah, I love to interact with more people, work with more people, and spread some of the good things that peptides can do, because they're absolutely amazing. And again, we barely scratched the surface. We didn't even scratch the surface on like TRT for women. That's a whole other topic. I feel like we slanted this towards men a little bit. So ladies, there's so much great info out there for you too, especially using testosterone. I'll definitely have to come back. This was a lot of fun.
Yeah, we're going to have to do a part 2, probably a part 3. There's a lot of stuff to discuss there. So again, thank you so much for coming on the show. Thank you so much, everyone, for listening. And always, I'll be back with another episode soon.